Thank you. It's all downhill from here. These are the objectives of the talk. This is the list of what I was given to talk about. Okay. Most of this is very small writing, so don't worry about that. You don't need to actually read it. I certainly didn't. Okay. But these are some of the things we're going to talk about. Now, some of this may be a little confronting for some of you. We're going to talk about treatments for cancer, both early breast cancer and advanced breast cancer. And one of the problems with the information out there is it's generic. It's to all women. So it may not all apply to you. Some of it I'm not going to go into detail, but some of the slides are a bit more detailed than they need to be. And that's purely to give you guys a menu, give you a list of the drugs that are out there or the options that are out there. It doesn't mean it's relevant to you. If you don't want any information about it, you can switch off and stop listening to me. I suspect by about halfway through, most of you will have done that anyway. Okay?
We'll let you know.
Yeah. So I guess, first of all, what is cancer? So cancer is not really just one disease. We think of it as a thing, but it's not. It's a collection of different diseases that describes how the cells are misbehaving. It's probably, if we talk about it from a molecular point of view or from a detailed point of view, it's probably 1,000 or 5,000 different diseases where each cancer almost is different in terms of exactly how it behaves. But we lump them all together because they are a little bit similar. And it's important to remember is to find by where it starts. So if you've got a breast cancer that spread somewhere else, it's still breast cancer. It still behaves in the same way that the breast cells are programmed to behave. And that tells us how best to treat it, how to manage it. So even when it's spread, it's still breast cancer. And it's been around for a long time. So the names that we use are from Latin and ancient Greek. So the words for swelling in Latin is tumor. Its swelling in ancient Greek is onkos, hence oncology. So it's not new. It'll still be around when my kids have gone through uni, hopefully. And it's going to be around for a long, long time, unfortunately. So a little bit about history of breast cancer. So there's hieroglyphics from ancient Egypt from about 3,500 years before history of a pharaoh's wife with a breast cancer. Now the average age of survival in ancient Egypt was about 40. So this woman would have been in her 30s, probably eligible for genetic testing, but probably didn't have it at the time. And you can see that she quite clearly had a mastectomy. Now, given they wouldn't have had anaesthetic in those days, it would have been a reed to bite on. Her post-op care would have been slightly more challenging. And the treatments we've had for breast cancer, apart from surgery, are also not terribly new. So Thomas Beaton, who was a doctor and scientist in Edinburgh in Scotland in 1876, came up with the idea of taking out ovaries to treat breast cancer. So he treated mice initially and then subsequently women, and he found that by taking out the ovaries, the breast cancer improved. And he had lots of crazy ideas as to why that happened, but we now know that's because taking away the estrogen can often control the breast cancer. And some of the more modern treatments we have do that in a slightly better way, but still effectively switch off the ovaries in premenopausal women to treat the breast cancer. So in some ways it's going first full circle. So this is my inner geek bit. This is the data, the numbers. Okay, it's not so much inner geek, it's just geek, it's outer as well. So if we look at all the cancers in Victoria in 2022, and one of the benefits of Victoria is we have the Victorian Cancer Registry is world leading in terms of how quickly we get this information. So every cancer in Victoria has to be registered with the Victorian Cancer Registry. They keep that data very up to date, so it's not quite real time. We get the data about 6 or 8 weeks afterwards. And that's sped up, particularly with COVID. It was one of their COVID plans was to keep up with the cancers. So this is the data from last year in Victoria, and this is the league table of cancers. So I don't know if you can read that, but prostate cancer is winning, and breast cancer is in second. Often those two will go change leads every now and then, every couple of years, depending on what we're doing in prostate cancer. Breast cancer is reasonably stable. But it's the second most common cancer. I've got to... You can see is this one here. So breast cancer is common, unfortunately. There are 46 Australian women diagnosed with breast cancer every day. There are also 3 men every week, so about 150 male breast cancers per year in Australia. The majority of those men will actually be gene carriers, so more than half of them will be BRCA2 carriers in particular. And the median age, the average age of women with breast cancer is 62. The average age around the world is fairly consistently about 10 years after the median age of menopause. So in Australia, the average age for menopause is 51. There are some other countries, depending on the genetics and the lifestyle and other things, where it's either younger or older, but the breast cancer median age tends to mirror that. It's about 10 years after menopause. And this is important. So 69% of women in Australia will be diagnosed between the age of 40 and 69. Why is that important? What's happened special with those women? They're the women that we screen. They're the women that are breast screen eligible. They get invited for breast screen from the age of 50. You can opt in to breast screen from 40 to 50. And the reason for that is if we can capture 69% of the breast cancers with that age group through screening, it makes it worthwhile financially. We could screen later, so we could screen up to 85. We could screen a bit early. We could start screening everyone from 35 or 40, and we would find more cancers. But you get more bang for your buck if you concentrate on that 70% of women that fall into that category. And you can see that as you get older, breast cancer becomes more common. So it peaks here, around 64, but it doesn't go down. Our data tends to stop at 80 or 85, but I had one very annoyed 86-year-old who said she was told her risks stopped at 85. I said, no, it just, the graph stops, but the cancer doesn't. Okay? You can't see it on that one, but just as one of the few men in the room, I should point out the male breast cancer risk is down here as well, but it's too small to see. And breast cancer is becoming more common. So if we look at the changing incidence, so this is back in the 1980s, we can see that we're now diagnosing more breast cancer than we did 40 years ago. And that is partly due to screening, that we're finding more breast cancers because we're looking for them. And it used to be that people died younger, so the average age of death used to be in the 80s was much younger than it is now. So people are living longer, living long enough to get a breast cancer, but we're also finding those cancers because we're looking for them through screening or through more checking, I guess. And in Victoria, the chance of being alive 5 years after your cancer diagnosis has significantly improved over that time. So if we look from 86 to 90, the 5-year survival was about 72%. So most women did quite well. Most women were around 5 years later after the diagnosis. But if we look now with the more modern data, 92% of women diagnosed with breast cancer are still alive 5 years later. And that's a significant improvement, partly because we've got better treatments, but partly because we're finding those cancers earlier, and therefore they're curable cancers rather than ones that we can treat, manage. And interestingly, even though we've got more cancer diagnosed than we did 30 years ago, 40 years ago, we can see the mortality, the rate of death from breast cancer, is dropping. So you can see the graph is coming down, suggesting there's less women dying of breast cancer than there ever was, even though we're diagnosing more of it. So it's all good news from a breast cancer point of view, okay? Okay, treatment. This is the complicated bit. Breast cancer is not all one thing. So as health professionals treating breast cancer, we talk about certain things in the breast cancer to try and stratify it, to define it in different ways. So we talk about estrogen receptor positive or luminal breast cancer. The estrogen receptors are on the outside of the breast cancer cell, and they'll be present in about 70% of breast cancers. And that kind of makes sense because the breast is designed to change during a lifetime. So your breast changes at puberty, at pregnancy, at breastfeeding, at menopause. And those breast changes are controlled by estrogen. You have effectively got an on switch within your breast cells where the estrogen in your body tells them to change, start growing, turn on. Most of the cells in our body do exactly the same thing their whole life. Your lung cells are designed to be a lung cell and nothing else. They have no imagination. Whereas the breast cells have the ability to change and they've got an on switch. And cancers, by pure dumb luck, use that on switch to grow. And that gives us an option in terms of turning off those cancers by blocking estrogen, that we'll talk about in a second. So they're the most common group. Those luminal breast cancers are the most common of all the breast cancers, the ones that we see in about 70% of women. We can subdivide it into A and B depending on whether it's high grade or low grade. That doesn't really matter for today. The next most common group is the HER2 positive. On the outside of these cancer cells, there are HER2 receptors. And we don't really know what HER2 does in the the rest of the body. We don't know what it's there for. But we know that about 1 in 5 breast cancers have this second on switch that may be there, as well as the estrogen. The estrogen may not be there, but that HER2, if it's on, is a superpower, if you like. It's a turbo boost for that cancer's growth. It grows much faster. And it used to be that HER2 positive breast cancer did worse than all the others. Until about nearly 50 years ago now, they developed a drug called Herceptin, which fits into those keyholes perfectly. And as a result, women with HER2 positive breast cancer do about the same as women who are HER2 negative. Okay? And then the third group, which is probably the most challenging to treat, is the triple negative breast cancers. So triple negative means we've looked for the 3 most common receptors. We've looked for estrogen, progesterone, and that HER2. And it doesn't have any of those receptors. It doesn't have any keyholes on the outside surface. And that just makes it a little bit harder to switch it off because there's no key to put in that door. And each of those cancers behaves a little bit differently. They're not better, they're not worse. It's more about how they're likely to behave and, more importantly, how we can treat them. What drugs work and what drugs don't work. And we do have what's called targeted therapies. So if you have a receptor on the outside of your cancer cell, we can target that receptor. We've got a key that'll fit in that keyhole to turn off that cancer cell. And we've got more and more options from that point of view that I'll talk about in a second. Okay. So we also divide breast cancer into early stage and advanced or metastatic stage. So early stage is stage 1, 2, and 3, where the cancer is contained within the breast or within the breast and the lymph nodes under the arm. It's just in that area. And the aim for early breast cancer is obviously to cure it, to get rid of it all. And as a result, with early breast cancer, we tend to be a little bit more aggressively, because if we throw the kitchen sink at this if we need to, there is a chance that it may never come back. That woman may be cured. And usually with early stage breast cancer, surgery will be a mainstay of treatment. It'll be the most important part. It's changed a little bit since the ancient Egyptians. The surgeons are neater. The anesthetists are much better. But essentially, surgery is still surgery. And we tend to do, I guess, less surgery now if we can. Certainly less than they did 100 years ago when they did a radical mastectomy where it was right down to the bone, right down to the chest wall. So we do as little as we need to, and ideally that would be done from a woman's point of view with reconstruction if that's what she chooses to have. Sometimes with early stage breast cancer, we'll use radiation, particularly if there's breast tissue left. We'll use hormone therapy, so estrogen blocking therapy, to mop up any cells, to switch off any cancer cells that could be floating around. And we might use other targeted therapies like trastuzumab or Herceptin. Now, one of the things I should say about these drug names is when a drug company names a drug, they make it deliberately hard to say, okay? And that's because trastuzumab is hard to say. Herceptin, their name for it, is much easier. So obviously we're going to call it Herceptin. So when it comes off patent, we still call it Herceptin. They're not stupid, these people. And all of these therapies are what we call adjuvant therapy. They increase the chance of the cancer being all gone. Now the problem is the surgeon has taken away all the cancer that we can see, so we have to guess as to whether there are cancer cells still in there. Obviously a highly educated guess, hopefully, but it's still a guess as to whether they might be in there or not. So these adjuvant therapies may be treating a possibility or a maybe or a chance that there could be cancer cell in there to improve the chances of you being cancer-free in 10 years' time. Sometimes we change it around and we give what's called neoadjuvant therapy. So as I said, breast cancer surgery has been around for 3,000 or 4,000 years. So in the last couple of years in particular, we've changed it around just to keep the surgeons on their toes. Sometimes we'll give the adjuvant therapy up front. So we might give chemotherapy or hormone therapy or targeted therapies first to shrink down the cancer, to make it easier for the surgeon to be able to get it all out. So if it's a big cancer and the surgeon says, listen, I don't think I can get that clearly, then if we shrink it down, it means that they might be able to. If we shrink it down, it might mean that they need to do less surgery. They may not need to do a mastectomy, they might get away with a lumpectomy. It also gives us time to tell us what's the cancer going to respond like to those drugs? If we give, for example, Herceptin up front, and we see the cancer shrinks but isn't gone completely, then there's no point in continuing with Herceptin afterwards, because we know that cancer in that moment didn't respond as well as we would like. So we give a different drug. So by leaving the cancer in place, we can see how it's going to respond. Now, for some women, that's a bit challenging, knowing that the lump is still there. But once they start to see it shrink, it tends to be a little bit more reassuring, but still a little bit nervous. It also allows us other times, so things like we can do genetic testing during that time frame. We can tee up breast reconstruction. We can sort out other things. I have a patient who had a heart attack around the same time as her cancer was diagnosed. She had the heart attack first, not the cancer, because otherwise someone would have said it was the diagnosis that caused her heart attack. As part of her heart attack treatment, she had to go on blood thinners, which meant we couldn't safely operate because you'd have to stop the blood thinners to do the breast surgery. So instead, she's on a neoadjuvant hormone therapy to shrink down the cancer to contain it while her heart recovers so that we can safely operate 6 or 12 months later. Okay? So this is becoming increasingly common, and we know that there are some subtypes that have worked particularly well. So triple negative and HER2 positive breast cancers tend to work quite well with this one because we've got a plan B if it doesn't completely kill off the cancer cells that we know are there. So advanced or metastatic breast cancer is when the cancer has spread beyond the area. It's spread to other organs, wherever that might be. And once it has spread, in general, for most women, it's not something that we can cure. We can control it, we can slow it down, we can improve their quality of life or their symptoms, but we can't get rid of it. And because we know that we're not likely to cure this, our treatments are less aggressive. It's more about containing it, doing just enough to control it, rather than the kitchen sink approach that we might use with early breast cancer. So the aims are different. It doesn't make sense to operate most of the time because the cancer's already spread. If you operate, you'll deal with the breast, but only the breast, whereas if we use systemic therapy, chemotherapy or hormone therapy or other drugs, it'll treat the whole body no matter where it is. So it doesn't always make sense to do surgery, usually. So those patients with stage 4 disease might have radiation to control a specific area, or hormone therapies if it's estrogen receptor positive, or other targeted therapies, including immunotherapy, that I'll talk about in a second. And these are some of the common sites that a breast cancer can spread to. Different subtypes of breast cancer will behave a little bit differently in terms of what they're likely to do, but these are all places that the cancer can go. Liver, lung, brains, bones. Bones is reasonably common. And as I said, it's important to remember that it's still breast cancer. It still behaves like a breast cancer. If we biopsy it, the pathologist will still say it's a breast cancer. So regardless of where it's gone to, we will treat the whole body with drugs that will go through every cell in the body. So when you're treating advanced breast cancer, the quality of life is key. So treating the cancer can improve symptoms like pain or swelling because we can shrink down the cancer or shrink down the spot in the bone or wherever it might be. But we can also improve the indirect effects. So what we often see in people with advanced breast cancer is they have not just pain from the cancer, but also things that the cancer is doing indirectly. So things like fatigue is common. Your body's busy fighting the cancer constantly, and as a result, it doesn't have time to do its usual things like make red cells, make your energy, make your appetite. It diverts all its resources into fighting the cancer. So by making the cancer less active, we can make your body overall feel better. So most of our treatments for advanced breast cancer will make a woman feel, or man, feel better, feel like they've got a better quality of life. If it's not doing that, then I'm doing something wrong, okay? And that's where this becomes very much part of a team effort. So the oncologist might say, I can give you these drugs, which one do you want? These are the side effects, these are the pros, these are the cons. And it's a decision made with a patient in terms of what's best for her at that time. So it might be that I'll do that one. My favorite one when I came down here, first of all, was someone said, I can't have chemo because we're crutching. I didn't want to Google it during the consultation. For those of you who aren't local, it's something to do with sheep. I still haven't looked at it. But it meant that it wasn't the time for her to be coming in on a regular basis for chemotherapy because she had other stuff going on the farm. And they're the kind of considerations that become important in advanced breast cancer. It's about keeping life reasonably normal. It's about keeping what's important to you going. And if that's sheep, then great. And there are so many options with advanced breast cancer that it's like a menu. You will eat everything in the restaurant eventually, but the order we eat them in can change quite a lot. Okay? So other treatments, apart from chemotherapy, if we've got anti-estrogen therapy. So blocking the estrogen can switch off that cancer cell. If it's got an estrogen receptor, the estrogen in the body is turning it on, it's making it grow. By blocking that, we can stop it. Most of our anti-estrogen therapy doesn't actually kill the cancer cells, it just stops them. But that gives enough time for the body to catch up and to discover those cells and kill them itself. So they're not as toxic as chemotherapy, because chemotherapy will hit any cell in the body that's growing. And when we started off in the 1970s, we had tamoxifen. Tamoxifen is a very good drug, but it's what it does is it's the same shape as estrogen from the body's point of view. So it binds to those keyholes, those receptors, and it blocks those keyholes, so they can't be turned on. The problem is that when you stop the tamoxifen, after a couple of weeks, everything goes back to normal again. So it's reversible. The aromatase inhibitors then were next. They came out in about the 1990s. They are a little bit easier to pronounce, letrozole and anastrozole and exemestane. These are all tablets. And what the aromatase inhibitors do is they block the enzyme that makes your backup generator of estrogen. So your ovaries produce estrogen when you're premenopausal. So for premenopausal women, there's a lot of estrogen around. So nowadays, we would often switch off their ovaries. So we do that with an injection, an implant that you get once a month, rather than the 1876 version where you take out the ovaries, which we do occasionally, but an implant is slightly easier for some women. When you go through menopause and your ovaries switch off, you've got a backup generator that makes a little bit of estrogen, an enzyme present in your fat cells. And that's what the aromatase inhibitors block. So they're a little bit more effective than tamoxifen. The newer agents are called SERDs, so selective estrogen receptor disruptors. What they do is they block those keyholes and they destroy the keyholes. So they're a little bit more effective, but more importantly, they're probably a little bit less toxic in terms of hot flushes, vaginal dryness, all of those, what we call vasomotor symptoms. The downside of blocking your estrogen. It's like a mini menopause, but a mini menopause for 10 years for some women. And then the other class of drugs are called the CDK4/6 inhibitors. These are drugs that work together with the estrogen blockers to make it a little bit more effective. And these have made a big difference for the lives of many women with advanced breast cancer. The reasonably low toxicity, very not common to get bad side effects, certainly nothing like chemotherapy levels, but it makes the rest of the drugs much more effective. Okay? And then sometimes again we'll use chemotherapy in those women, but if we can get away with hormone therapy, that would be preferable. And then if they're HER2 positive, this is where we get back into the fancy names again. We've got a number of different drugs, all of which target the HER2 receptor in a slightly different way. So trastuzumab, pertuzumab, trastuzumab emtansine, and trastuzumab deruxtecan. This is the most recent one, and I still can't pronounce it properly. So we call it TDX. There's also targeted therapies. All of these will target the HER2, and some women can be many, many years on these targeted therapies. Now, because these are hitting only the HER2 positive cells, they don't have chemo side effects. So they're only hitting the cancer cells and doing very little else to the rest of the body. So generally speaking, women who are on these drugs can have a fairly normal life, apart from having to come and see me every 3 weeks or so. And then there's the triple negative breast cancer. So this has always been the hardest to treat because it doesn't respond to blocking estrogen. It doesn't respond terribly well to chemotherapy. And this is where they put most of the research in the last few years into drugs to treat triple negative breast cancer. And we know that immunotherapy works a little bit. So immunotherapy switches on the body's own immune system and tells your immune system to get off its butt and get rid of this cancer. And it works a little bit, not as well as immunotherapy in some other cancers like melanoma or lung cancer, but it works a bit. And probably the most exciting, we call this one SG, okay? I'm not even going to try and pronounce it, is what we call a drug-antibody conjugate. This is where the scientists have gotten very fancy. So they develop a target that will attach to your cancer cells, and they develop a little packet of chemotherapy attached to that target. So when the molecule of drug attaches to the cancer cell, it releases its explosion of chemotherapy and kills off those cancer cells. So it's like a smart bomb. It'll go to the cancer cells only and deliver chemotherapy to them. So it's very effective. But the problem is finding the right target. So with estrogen receptor positive or HER2 positive, we got easy targets. With triple negative, by definition, we don't have great targets. So that's where all the research is going into developing a target that we can then make a smart bomb to target that. Okay. So many women with advanced breast cancer will get different lines of therapy. We try one drug. After a while, that'll stop working. So we try a different drug. Sometimes we use a combination of drugs. Sometimes drugs will have different sets of side effects that might be important at different times. But it's all about managing the potential side effects with the planned benefits. So we want to make sure that the quality of life is overall better. We might use other therapies like bone-directed therapy to strengthen the bones. As we shrink down the cancer, we don't leave holes behind. But resistance in advanced breast cancer is inevitable. And the reason for that is your body, your human body, is incredibly complex. Every cell has a whole load of backup mechanisms. If one fails, you've got a second one and a third one and a fourth one. And the problem is cancer cells also have those benefits. If we block one pathway, the cell will switch to plan B, and then plan C, and then plan D. So every time we're playing catch up in terms of blocking those cancer cells. The cancer cells aren't smart, they're not clever, they're just trying different things constantly, and there's lots of them. So they get through by pure dumb luck, and our scientists have to be slightly smarter than that. Okay? So it is improving, but there's still a long way to go. So how do we choose who gets what treatment? Well, sometimes it'll be dependent on what symptoms the patient has with advanced breast cancer. Sometimes it'll be their age. So if it's premenopausal, if it's postmenopausal. If it's a 96-year-old versus a 36-year-old, we'll have different options and different choices at that stage. It depends on how fit the patient is. We have a scale called the ECOG scale. And the ECOG scale, if your oncologist ever asks you how active you are, it's because he's trying to assign you a score on the ECOG scale. And a couple of years ago, the ECOG scale was developed in the 1940s. It's a scale from 1 to 5, where 0 is perfectly fine, 1 is a little bit off, and so on. And a couple of years ago, they got upset because someone did testing on patients, and the patient said, I'm ECOG 1, I'm fairly fit, I'm doing lots of things around the house, I'm playing bowls and golf and everything else. And they put accelerometers, so things like which I have in your phone nowadays, your step counter, something to measure how active you actually were. And they found that everyone was lying. And they said, oh no, our scale's all wrong, we need to redo everything we've ever done. And then they tested doctors and nurses and found that they also lied. So for all lying consistently, the scale still works. Okay? It can depend on other things like how well your kidneys or your liver are working, because we need them to clear the toxins out after we pump the toxins into you. So if your liver's not working, for example, the drugs might last longer in your system and you might get more side effects. Whether the cancer is spread to just one area or many areas, if it's just one area, we might be able to control that with radiation. Radiation is good for spot welding, as I say, where you can point it where you need it to go and it'll treat there, but only there. And it's very good for things like bones or brains or other bits that are hard to get at with chemotherapy. And it'll also depend on what you've tried before. If we tried something before and it didn't work, it doesn't always make sense to go back to it again, because those cancer cells had already shown they worked out how to get past it. Oh, I have to talk faster. Okay. As I said, all cancer cells will at some stage develop resistance. By pure dumb luck, they work out how to grow despite getting blocked. And all of our research in the lab is based on things like this, how to work out resistance. This is deliberately hazy, okay? So don't worry, it's not your eyesight. This is just to explain, this is the kind of thing that the lab scientists do. They work with a cell in a model and see what happens if I switch this off. Because in your normal cell, you've got a whole load of backup pathways. If you switch this off, this will get turned on. If we switch that and that off, what happens over there? So there's a whole load of switches, and what they do in a lab is work out what happens, what order do I need to block the switches in to turn off everything. I like trying to turn off the TV sometimes. I just get my kids to do it. So that's what the lab-based research is based on developing resistance mechanisms, work out how it happens first, and then drugs to block it when it does happen. So most of our research is about how we can prevent cancer spreading in the first place with early disease, or make those treatments less toxic. For example, SERDs are less toxic probably than our older drugs. But also in advanced disease about having more effective and less toxic treatments and overcoming resistance. Okay. I'm going to talk about genetics for a bit. I should say I did my doctorate on breast cancer genetics, so I could talk about this for days. So there are certain risk factors for breast cancer. The biggest risk factor for breast cancer is obviously gender. Women are much more likely to get breast cancer than men because of all that estrogen. And one of the issues that's becoming an increasing problem is how we address transgender people because their estrogen levels aren't actually physiological, but we will in the future see transgender people be getting breast cancers more commonly. Age is also the biggest risk factor, and no matter what serum or cream you use, you cannot stop age, okay? Doesn't matter how expensive the gook is. Your family history and genetics are also two factors that you can't change. So when we talk about genetics, we talk about specific genes that are associated with breast cancers, and they can run in families. But we also talk about family history separate to that, because the information in between genes is also important. I won't bore you with that, but they're called SNPs, and they're something you can also inherit, but they're much harder to see and much more variable than the actual genetic information. Your estrogen exposure. So again, back in the 1700s, someone wrote a paper about nuns and their different cancer risks, where they found that nuns were more likely to get breast cancer and get cancer of the womb because they didn't have kids. So we know that estrogen exposure, so having your period start young and stop late, gives you a longer period of estrogen exposure and therefore a higher risk of breast cancer. Having kids, having them early and having them often and breastfeeding them reduces your risk of breast cancer. So kids are actually useful for something. Obesity increases breast cancer risk. We don't exactly know why. There's two possible reasons. It could be related to estrogen, because we know, for example, the aromatase, that enzyme is present in your fat cells, so there's more aromatase around in people who have more fat cells. But also it's obesity is pro-inflammatory, and obese people have more inflammation going on, which can lead to various cancers. And alcohol also increases your breast cancer risk. Now, as an Irishman, there's no such thing as too much alcohol, but realistically there is. So we know that excess alcohol, so drinking more than me, increases your risk of breast cancer. These are some of the breast cancer genes that we know to test for. Okay, so BRCA1 and BRCA2 are probably the most well-known of them. BRCA2 was discovered 25 years ago, so most of this is very, very new. That's the panel of 8 genes, and there is only 8 of them there. RAD51C and D are on the same gene. They're the 8 genes that we test as part of a panel for breast cancer risk. So when we're doing genetic testing, we send off a blood sample, 2 teaspoons of blood. We send that off to Peter Mac, they extract the DNA from that, and they test those 8 genes, looking for spelling mistakes in those genes. And that's what BRCA1 looks like. I love this slide. My kids last night said, "Dad, you're not still using that slide, are you?" Anyone want to tell me who that is? Angelina Jolie. That's what BRCA1 actually looks like. Angelina Jolie, about 10 or 15 years ago, had an article in the New York Times about her BRCA1 mutation. Her mother had cancer a number of times. She had genetic testing in her late 20s. She was found to be a BRCA1 carrier. She had prophylactic mastectomies and reconstruction. She had her ovaries taken out in her early 30s to prevent ovarian cancer. She chose to adopt her kids rather than having kids because she didn't want to pass it on. And she wrote a very good piece that had widespread coverage around the world because it was something that hadn't been talked about before. So in genetic terms, we talk about the Angelina Jolie effect because we saw a massive spike in women coming to their doctors and saying, I want genetic testing like Angelina Jolie. I also had a number of husbands and partners saying, if she had the gene, would she look like Angelina Jolie? It doesn't work that way, I'm afraid. So it made it more aware for the general population about these genes and what we can do about these genes to prevent breast cancer. And for those of you who care, BRCA1 is on the long arm of chromosome 17. Okay? Okay. So genetic testing is a simple blood test. The cost at the moment is about $450 for that 8-gene panel. When I started doing a genetics clinic at Peter Mac in 2010, it cost just under $3,000 to test for 2 genes. And the waiting time for the results was about somewhere between 6 months and 12 months, depending on how you caught them. Nowadays, the turnaround time is somewhere between 8 and 12 weeks, depending on who's going on holidays. We had a big problem actually with the genetic testing during COVID because all the scientists in all the labs got diverted to doing COVID testing, and as a result, everything else fell way behind. But they're nearly caught up now. Medicare will pay for genetic testing in Australia if your predicted risk of carrying a gene is 10% or more. It's a very arbitrary cut-off point. And there's a few ways that we can work out a woman's risk of breast cancer, of carrying a breast cancer gene. There is an argument we should test everyone, but the problem is we don't have the resources to do that. Nowhere in the world have the resources to test every woman. When it becomes cheaper and quicker and easier, the holy grail would be to have machines in the supermarket where you stick your finger in and it says BRCA1. The problem with that is we need genetic counselling. So it's not a straightforward blood test. There's lots of things to consider before you decide whether you want to have it or not. It has implications for your family, because if you're a gene carrier, there's a 50% chance that your kids could be gene carriers, or your sister, or your parents. So it has what we call a ripple effect, cascade testing. So we calculate the risk before we decide to test. We educate the woman and her family as to what the implications of that test are as part of the counselling. And the Victoria is actually split up into different regions from the genetic clinic's point of view. So the Royal Melbourne Familial Cancer Centre does all the genetic testing here in Warrnambool in the region. And they do a clinic, they used to do a clinic pre-COVID every quarter in the hospital in Warrnambool. Nowadays they do most of the genetic testing and things via telehealth, so you don't need to wait necessarily for the next clinic. I have an appointment at that clinic so I can do the genetic testing myself and skip the queue. I don't test myself, obviously. I don't want to know. So as we get better in terms of research, the testing is getting cheaper. How we estimate your chance of carrying a gene gets better, and how we estimate the chance of getting breast cancer is better. So the ideal would be in the future that instead of treating the whole population as one risk, say all women are at increased risk of breast cancer, if we take the whole population, the risk for a woman is 1 in 8 in her lifetime. But if we say, this part of the population are lower risk, we don't need to keep as much of an eye on you. This part of the population are moderate risk. They're at higher risk than those people, but not as high risk as the gene carriers. And we might do their mammograms more often. And then there's the high risk people who account for about 1% of the population. We need to do more testing for them, or do prophylactic mastectomies, or do more intensive. So having what we call a stratified risk is better. There is a tool called iPrevent that's available for free. It's on the Peter Mac website. There's a link to it on the BCNA website and a few other websites around. That's a tool that a woman can put her information in terms of her age, her weight, her family history, her cancer history, and it'll calculate your risk of getting breast cancer for unaffected women. For those of you who've had breast cancer, it's not so accurate, but it's useful for families or younger women who want to know what should I be doing about my risk. Should I be having mammograms more often? Should I start them earlier? Should I have genetic testing? And that'll tell you it all. brilliant piece of work. I developed it when I was at Peter Mac too. As someone pointed out, I'm colourblind, so some of the colours on eye prevent are slightly odd. Not to me. Okay. The other thing I should have talked about, I guess, it's not so much genetics as what we call genomics, but it kind of goes together. When I talked about dividing breast cancers into luminal or ER positive, HER2 positive, and triple negative, it's a very crude definition of those cancers. That we can do better than that with science using an individual's tumour and see within that tumour what genes are switched on and switched off. So instead of saying this is the same risk for, or the same chance of something bad happening for 20% of women, we can say for that tumour, the chance of this tumour coming back is X or Y or whatever it might be. And that genomic testing is unfortunately not funded in Australia. The first of those tests was called Oncotype, and it's not done in Australia because the company won't allow anyone to do it outside the US and Ireland. But it's unfortunately not funded here. It costs about $5,000 per patient. Some women opt to do that if they can afford to self-fund it, because you can say therefore with much greater detail whether you need chemotherapy or whether you're going to do very well without it. So it's a bit like the crude subdivision of breast cancers, but at a much more detailed individual level, but unfortunately not fully funded. And I think it's been an ongoing BCNA crusade to try and get that funded for more women. In Ireland, where I trained, all women were eligible for Oncotype if the oncologist thought it was appropriate, which is unfortunate because there's actually cost savings. So if the government did pay for it, then we wouldn't have to give as much chemotherapy or have to give as much other treatments because we'd have more details about the risk. So it does actually save money in the long run. But anyway, we need an election year to fix that. So the take-home message, and this is my last slide. Thank God, she says. Breast cancer is common. Okay, as I said, 1 in 8 women will get breast cancer in their life. But if we looked at the families touched by breast cancer, it's almost universal. Most families will have someone with breast cancer, unfortunately, affected. There are lots of treatment available. There's lots of things that we can do to prevent that breast cancer coming back, to treat it, to control it, to do something to improve that woman's life. And those outcomes are very good and getting better. So there are more and more women doing better and better with breast cancer. Early diagnosis is good through screening. Prevention is better. And there are ways that we can do that to help reduce the risk and to basically manage that process even better again.